So good morning again and welcome to our Department of Surgery Grand Rounds. It is 8:01 and we have quite a few attendants, and I'd like to get started so that everyone's day can kick off. And we welcome you all. It's good to see all of these names from both near and far. This morning we are very pleased to have Dr. SRIKANTH GARIKAPARTHI, a member of our surgery department and esteemed lecturer and consultant in plastics and general surgery. Dr. GARIKAPARTHI was born in Hyderabad, India. He is board certified in general surgery and plastic surgery, and he has a fellowship training in hand surgery. He's a fellow of the Royal College of Surgeons of Edinburgh. Dr. SRIKANTH, as he is affectionately known by all of us, moved to the Bahamas in 1999 to join the Department of Surgery at the Princess Margaret Hospital as a trauma, general, and plastic surgeon. He established the plastic surgery unit with a dedicated clinic, operating time, and burns unit. Teamed with Dr. Colleen Fitzcharles, their plastic surgery services expanded to treat patients with hand problems and provide comprehensive hand surgery. Dr. GARIKAPARTHI is also a lecturer in surgery at the University of the West Indies School of Clinical Medicine and Research at our Bahamas campus and has been since 2002. He truly loves teaching and sharing his knowledge and skills with up-and-coming young Bahamian doctors, for which we are all so grateful. So without further ado, I'd like to welcome Dr. SRIKANTH GARIKAPARTHI to do a presentation for us on peripheral nerve injuries. Dr. SRIKANTH, whenever you're ready, you can take over.
Okay, so this morning we're talking about peripheral nerve injuries. Peripheral nerve injuries are not life-threatening, but they are life-debilitating. So it's important to understand and treat these injuries in a timely and an appropriate fashion. What are our objectives for today? To understand the anatomy and physiology of the nerve, the pathophysiology of a nerve injury, be able to classify nerve injuries, how do we clinically and diagnostically identify them, how do we manage them, what are some of the special things that plastic surgeons we get called upon, and what are some of the advances that are there in this field presently. Because my talk is not catered to my peers, but to a wider audience, some of it might be very basic to begin with. So the nervous system in general consists of nerve cells and glial cells, the supporting architectural cells. The neurons themselves have a simple anatomy. They have a cell body or a soma. They have multiple small dendrites, and then one of the longer terminals is called an axon. The axon is covered by Schwann cells, which produce myelin. They're interrupted at the nodes of Ranvier. The myelination process speeds up transformation of signals. The glial cells, there are a couple of them. The astrocytes are the majority of the cells. Microglia and oligodendrocytes are all these three are predominantly found in the central nervous system, whereas Schwann cells are found in the peripheral nervous system. The oligodendrocytes in the central nervous system and Schwann cells in the peripheral nervous system produce the myelin, and they form the myelin sheath. Then there are smaller satellite glial cells and ependymal cells. The neurons themselves are different ways they can be classified. Fundamentally, in a functional classification, you have sensory neurons, you have motor neurons. Both these form the peripheral nervous system. But there is a third type called the interneurons that help interlinkage the various neurons, and these are confined to the central nervous system. Structurally, the neurons can be divided into three types. They are multipolar, the classic description I gave. There's many dendrites and one axon. And these are commonly found in the motor and the interneurons. Then you have a bipolar neuron, which has one dendrite and one axon attached to the cell body. These are classically found in the eye and the ear. And then there are the unipolar neurons, which has one process from the cell body, an axon. It branches into different types, and then there are dendrites at the end. These are commonly the sensory neurons. If you look at this picture, you realize that the central nervous system is basically your brain and your spinal cord, and your peripheral nervous system is all of the different nerves that are labeled and named across the entire body. There is a peripheral sensory representation of all these nerves that is well depicted in this diagram, that most of us should be aware about. What is the peripheral nervous system, or the peripheral nerves that we're talking about? These are the nerves and ganglia outside of the brain and spinal cord. They're not protected by the skull or vertebral column as the central nervous system is, does not have a blood-brain barrier, and they're divided into both a somatic and an autonomic nervous system. So they carry nerve fibers for both. What about cranial nerves? Do we know what category do they come under? Peripheral or central? Cranial nerves 3 to 12 are, which is other than your olfactory and your optic, are all peripheral nerves because their axons extend beyond the brain and the brain stem. Cranial nerves 1, 2, and the so-called cranial nerve 0 or terminal nerves are extensions of the brain matter. The cranial nerve 0, a fun fact, is a terminal nerve, also known as cranial nerve 13. It's been discovered in sharks almost 150 years ago, and in humans a century ago. They are adjacent to the olfactory nerve by the cribriform plate, and their function is really in sensing of pheromones. They're still being evaluated. Cranial nerve 1 is one of the few nerves capable of regeneration, and there is a lot of research on how to repopulate and re-stimulate one's olfactory senses. Peripheral nerve system has the ability to grow and therefore are different from the central nervous system. Once damaged, your central nervous system does not grow. Your peripheral nervous system has the ability. What is the anatomy of a peripheral nerve? It's basically multiple nerve fibers and connective tissue. The connective tissue consists of an endoneurium, also called the endoneurial tube, channel, or a sheath, is a very thin, delicate protective layer of connective tissue around each axon. Then there is perineurium, which is arranged like an onion peel layer, 7 to 8 concentric layers around fascicles. And these fascicles consist one or more neurons. Perineurium is the most important structure of the peripheral nerve because it protects, it supports, and it provides strength to the nerve. It also allows passage of molecules from the epineurium into the fascicle. The epineurium is the outermost layer of dense connective tissue. This makes up majority of the nerve, and it comprises 60 to 85%. Then an important structure called the mesoneurium. This is the loose areolar tissue around the nerve that permits nerve gliding. This is very important because it also has the vascular pedicles that go and supply the nerve, the vasa nervosum. The nerve fibers themselves are classified based on their size, their myelination, and what they conduct or transmit. So they have different classifications, the Erlanger and Gasser classification, which is classified into A, B, and C. The A itself is divided into alpha, beta, gamma, and delta. Each of these nerve fibers carry particular stimuli. And as you go down from A to C, the diameter of the nerve decreases, the velocity decreases, as well as the myelination. So C, which basically is the dorsal root ganglion or the sympathetic nerves, are unmyelinated small fibers, and they have a slower velocity because they're unmyelinated. As you know, if you look in this particular table, as the diameter decreases, its sensitivity to nerve block increases. The larger the diameter of the nerve, their nerve block is much more, they're less sensitive. As a result, you need larger volume or higher concentration. The nerves are also functionally segregated. Sunderland, who is one of the pioneers in nerve surgery, showed that nerve fibers travel segregated over considerable lengths based on their function. This has been extensively studied and proven in the brachial plexus. The segregation of the nerve fibers is established more proximally. As a result, there are certain nerve fibers that are supplying a certain group of muscles or a certain area are present together in a bundle. This is important for us because while we are identifying the nerve, cut ends of the nerve, we need to co-opt the proper and match the proper ends to each other so that the proximal part of the nerve reaches its target end organ. Sometimes the segregation is also useful because we can then transfer a single fascicle to re-innervate another muscle, as we would show you in nerve transfers. What happens when there are nerve injury? Let's talk about these changes. There are 5 different zones that we need to consider when a nerve is injured. The neuronal cell body, the proximal segment of the axon, which is between the cell body and the injury site, the injury site itself, the distal segment, which is between the injury site and the end organ, and the end organ itself. Let's consider each of these areas, what happens when there is a nerve injury. Immediately when the nerve is injured, there are changes that happen in the cell body. I will tell you why this happens. But what you see is a chromatolysis, which is the nucleus migrates to the periphery and the endoplasmic reticulum disintegrates. The metabolic function of the cell, which was until the time of the injury, was used for transmission of impulses, now changes from synaptic transmission to producing molecules for growth and repair. These factors that influence this change include GAP43, tubulin, and actin. What happens to the proximal end of the nerve, the part of the axon that is before the nerve? It swells, as you expect after any trauma, and experiences some retrograde degeneration. The axoplasm that is arising from the proximal axon segment is now traversing from the cell body towards the proximal end that has been cut. Once the debris is cleared, it begins to sprout axons. This is the growth cone. And this happens within the first 72 hours. What happens to the distal end of the nerve? This is what we classically have studied, called the Valerian degeneration. The axon distal to the injury, which is further from the neuron cell body, disintegrates or degenerates. This is initiated by lack of essential axonal protein, nicotinamide mononucleotide adenyl transferase 2. The axonal skeleton disintegrates, the axonal membrane breaks apart, followed by degradation of the myelin sheath and infiltration by the macrophages. The macrophages, accompanied by the Schwann cells, starts to clear the debris from the degeneration. In terms of timeline, within less than 24 hours, the neurofilaments break up, the axons break up into short lengths. Within 10 days, the myelin sheath breaks down into lipid droplets around the axon. Within a month, the myelin gets denatured chemically. And within 3 months, the macrophages from the endoneurium have invaded the degenerating myelin sheath and access cylinder and phagocytize the debris. What happens in the end organ itself? The muscle immediately starts to atrophy once you do not get any nerve stimuli. There is a decrease by 70% by 2 months. There is proliferation of fibroblasts within the intermuscular fibers with increased deposition of collagen. Then these get deposited between the muscle fibers. The motor end plates surprisingly are preserved for up to 1 year. So this is important to know and understand, because when you repair the nerve and you have done a quality repair, and when the nerve can reach the motor end plate before a year is up, you can still get some quality muscle function back. But remember, the quality of regeneration is also affected by the intramuscular fibrosis, and the quality and quantity of functional connections formed by the nerve within the muscle and cross reinnervation, which means in the muscle, we all know that there are fast fibers and slow fibers, and these are supplied separately by their individual nerve fibers. And you expect that the fast nerve fibers go back to the fast muscle fibers, and the slow nerve fibers go to the slow muscle fibers. If there is cross innervation, then if there is a lot of cross innervation, then your quality of recovery is not going to be good. This prevention of intramuscular fibrosis is important and brings in the need for a quality therapy while the patient is recovering from the nerve injury. What are some of the sensory changes? There is an absolute decrease in sensory receptors after 12 months of denervation. That means the total number of receptors that are present per square inch or per square centimeter start to decrease, as again by the motor end plates, but these are preserved up to 12 months. The same factors that affected motor recovery also affect the sensory recovery in terms of the quality regeneration. It is the failure of the sensory axon to reach the skin, the cross reinnervation, and possibly degeneration of sensory receptors. The fifth area that I didn't put up here is the site itself. So it is important that the surrounding area of tissue damage needs to be properly evaluated. If there is extensive tissue destruction and there is excessive scar formation, that will impede your quality of nerve regeneration. What happens once the nerve is now begin the process of regeneration? Once the chromatolysis in the cell body is reversed, when the axon is prepared for regeneration, the growth cone, which is at the proximal end, at the end of the proximal segment, has the ability to produce protease, which allows it to digest any debris in its pathway, and as it is regenerating towards the distal site. The Schwann cells in the distal nerve grow in ordered columns along the endoneurial tube, creating a band of Bungner cells that protect and preserves these endoneurial channel. And there are certain factors that I'm going to talk about in my next slide that will promote the growth cone towards these band of Bungner cells. The Schwann cells secrete laminin and fibronectin that directs the growth cone from the proximal nerve. It is also important to notice that the distal endoneurial tubes become smaller in diameter approximately 4 months after an injury. So it is important that you try and do these repairs, that the proximal segment reaches the distal segment, so that the regenerating axons can enter the distal endoneurial tubes. So even though the endoneurial tubes are smaller in diameter, the minute the axon enters into it, it can actually stretch and accommodate the growth of the axons. An important factor in promoting this nerve regeneration is the presence and secretion of neurotropic factors.
The banana.
These promote survival and growth of neurons. They act through retrograde transport of the neurons, and have both autocrine and paracrine effects. In general, these neurotropic factors are protein ligands for tyrosine kinase receptors. The best characterized, best studied neurotropic factor has been the nerve growth factor. Normally, it is involved in nerve cell survival and maintenance in the normal state. It is tonically released from peripheral nerve target organs and transferred to the nerve cell via retrograde axonal transport. Its decrease after nerve injury stimulates nerve repair. The ciliary neurotropic factor has typically a high level of expression in the Schwann cells in healthy nerves. But once in response to nerve injury, the CNTF decreases distal to the injury site and remains low unless the injured axon begins to start regrowing. There are some other insulin-like growth factors that are being studied. And then there are neurite promoting factors, the fibronectin and laminin that I've already spoken to, that are produced from the Schwann cells that attract the growth cone towards the cells of Bungner. You also have neural cell adhesion molecule and encadherin. So in summary, what happens when there is a nerve injury? The nerve will begin to degrade distally. The axon and the myelin sheath begins to degrade. The proximal cell body has chromatolysis and prepares the cell for regeneration. The axoplasm flows through to the proximal segment, forms a growth cone, and then these proliferating growth cone are attracted towards the Schwann cells that have formed the Bungner cells and are directed back into the distal segment. All of this is important to understand why we need to evaluate the type of nerve injury and how we have to deal with the type of nerve injury. It is therefore important to come up with a classification of the type of nerve injuries that we are dealing with. There is this classic Seddon's classification, which broadly divides the nerve injuries into neuropraxia, axonotemesis, and neurotemesis. Sunderland went ahead and further subclassified the neurotemesis because it's important to understand the different grades of it. In neuropraxia, which is Sunderland's grade 1, the tissue that is injured is the myelin, the covering. So there is physiological interruption of your synaptic transmission. Whereas in axonotemesis, which is grade 2, the myelin sheath and the axon itself is disrupted, but the architecture of the nerve is preserved grossly. As a result, recovery is possible without intervention. In neurotemesis, you have, under Sunderland, 3 grades, 3, 4, and 5, with increasing disruption of the entire nerve. In grade 5, there is complete separation of the nerve with a gap between the proximal and the distal segments. How do we identify these nerve injuries? First is to have a proper history. Evaluate the type of injury, whether this is a penetrating injury or this is a closed injury, whether there is a traction injury, traction involved. Look for motor and sensory deficits. Remember the first picture I showed you about the various sensory areas, but each nerve has an autonomic zone, which means that is supplied by that particular nerve or by the nerve segment alone. There is no overlap. So always look for the most autonomic zone. Also need to understand the motor innervation, and therefore important to identify the individual muscle and the muscle deficits. The pitfalls in clinical examination are that there could be a variable sensory distribution, and therefore again important to identify the autonomic zones that we are dealing with, each individual nerve. When it comes to motor examination, you need to be aware of trick movements, which is the compensatory activity of uninvolved muscles leading. For example, when you are looking for extensors at the fingers, you need to be careful that you're looking for the long extensors and not the short extensors, which are the lumbricals. A sure sign of axonal disruption, that is a peripheral nerve injury, is an autonomic defect. That means a dry skin, which is not sweating, is a sure sign that you have had a nerve injury. It's also important in open injuries, when you have penetrating injuries, to have a very high clinical suspicion of how to be able to identify these nerve injuries. There are certain associations. For example, when you have a laceration at the level of the wrist, and if you see the palmaris longus tendon is cut, you have to suspect the median nerve is injured. Similarly, if there is an ulnar sided wrist laceration and you have a bleeding vessel, which is more than likely an ulnar artery, a pulsating bleeder, the ulnar artery is cut, you have to assume that your ulnar nerve is divided. Similarly, in closed injuries, you have to analyze the force of injury. If there was a traction involved, in our communities, we have a lot of these motorbike accidents wherein these patients are flung from their vehicles and they end up having traction. How do we identify this? By linear bruising that suggests linear traction to the longitudinal structures, suggestive of traction injuries. In closed injuries also, you have associations. So when you see a humerus fracture, you want to think about circumflex or radial nerve injury. And it is imperative that in the clinical examination of these patients, you look for these injuries. In supracondylar humerus fracture in a child, you want to make sure that their median nerve is not being compromised. Similarly, when you're dealing with a hip dislocation, the sciatic nerve, and knee dislocation, the common peroneal nerve. So whenever you see this is your history and your clinical examination. You have to look out for your nerves. In addition, it is important to identify the type of injury that we are dealing with, because as research has shown, this is probably one of the more important determinants in terms of outcome. If you have a tidy injury versus untidy versus a closed traction injury, the closed traction injuries have really the most poorest outcome in terms of their recoveries. The clinical examination, we use Tinnel Sign very commonly. What is Tinnel Sign? Tinnel Sign is elicited by light tapping distal to proximal, from a distal to proximal along the course of the affected nerve. Now, Tinnel Sign is not very important in the acute phase, especially when you're penetrating trauma, but it is a very important clinical sign and has a lot of significance. It is usually positive within the first 6 hours after an injury. So when a positive Tinnel sign is there over the site of the injury, that indicates that the axons are ruptured. There is a disruption of the axons. If you have a Tinnel sign that is stronger distally than at the sign of injury, than at the site of the injury, that means it's a regenerating axon. If the Tinnel sign is stronger at the suture line than at the growing point, that means there is a mild Tinnel sign distally, but at the site where you repaired, the Tinnel sign is very strong. That repair is not very good. It's a failing repair. The Tinnel sign does not progress at all. There is a Tinnel sign right at the sign of your injury, which means the nerve has been not repaired, or it is re-ruptured, or there is another lesion that is impeding the regeneration. In addition, it is important to understand that Tinnel sign advances more quickly in axonotemesis than after a nerve repair. Obviously, the nerve sheath and everything is intact. Therefore, there is an unimpeded advancement of the regenerating axonal cells. It is also faster in the proximal segment of the limb than the distal segment. Classically, we talk about Tinnel sign being 1 millimeter per day or an inch a month. In the proximal segments or after axonoptosis, it can be up to 2 millimeters a day. What about use of electrodiagnostic studies to help us with identifying nerve injuries? So you have both nerve conduction and electromyography. Their role in the acute setting is kind of limited. And even within the first 10 to 14 days after injury, the results should be carefully interpreted, especially if you're dealing with incomplete lesions. Initially, it cannot reliably differentiate a neuropraxia injury from axonotmesis or neurotmesis because you need to have Valerian degeneration in the first few days. So if you were to do a nerve conduction study, there is a conduction block in neuropraxia, but distal waveforms are all normal, and the electromyography, there is normal recruitment. Maybe in the initial phase there might be a little bit of decreased recruitment, but it might come back to normal pretty quickly. Whereas with axonotmesis, where there is an axonal interruption, there is definitely conduction failure, there is conduction block. And remember, I said in the initial 4 to 5 days, it does resemble like the neuropraxia. Once the Valerian degeneration sets in, you start seeing flat line. And then in the distal form, until your recovery happens, you don't get it anything. And in your EMG is always abnormal activity. In neurotmesis, where there is complete transaction, there is complete blockage of the conduction. There is no waveform activity distal to the lesion, and there is abnormal activity in your muscle, which includes fibrillation. So it's important to understand when to order these tests and the interpretation of these tests. Now let's get into the meat of the matter. How do we repair these nerves? So whenever we have a suspicion of a nerve injury, it is important, and unless there are specialized conditions, or if it's a closed injury or there is evidence of traction, we tend to operate on these patients. It is important when we are doing these cases that we have excellent preoperative documentation in all these patients, because you want to document that there was a pre-existing injury to the nerve before you begin the operation. One of the most litigious areas is nerve injuries, especially with fractures. Remember the principle of limb surgery, life over limb. So if you have a complex limb injury, but also life-threatening injuries, that takes precedence. And in those situations, you only do damage control. You debride the wound to the best of possibility. You repair your vascular structures. You tag your nerves, both the proximal and distal ends, and you get out. Whenever you operate on definitive nerve injury patients, you prefer to operate under general anesthesia because of the sensations that the patients will exhume, and they're not very cooperative. And you want to avoid muscle relaxants, because if you are going to use muscle intraoperative neurodiagnostic testing, muscle testing to identify the nerve fascicles and the nerves, it's important to avoid your muscle relaxants. You always need adequate exposure, and you need to understand the anatomy of your nerves. You have to be able to expose them widely. You need proper surgical magnification. And when it comes to the nerve itself, you need to resect out the damaged nerve. So whenever you resect the nerve, you have to come across a healthy sprouting axons from each end of the nerve. Do not forget to prepare your bed. Remember the zone of injury. You have to make it healthy. You have to debride, lose necrotic or avascular tissue, and make sure that you have no bare bone, bare tendons exposed in proximity to your nerve repair. The type of nerve repair, we usually tend to do a direct repair after mobilization. There are a couple of varieties of nerve repairs that you can talk about: the epineural repair versus the perineural or the fascicular repair. This picture shows you the epineural repair, where you bring the epineurium together and you leave, and you tend to use this for nerve with much less axons within the nerve, more likely for the digital nerves in the digits or in the palm. Whereas with the mixed nerves or larger diameter nerves, you want to match the individual fascicles. As a result, you do a perineural repair, a fascicular repair. You line up the few of the fascicles, and then you put your epineural sutures on top of it. When do you repair with grafts? So remember, nerves do not have a lot of flexibility in terms of mobilization. At the most, you can actually lose up to an inch, 2 to 3 centimeters. You can mobilize these nerves. There is a mesoneurium. Remember, I talked about the mesoneurium that you can dissect for some distance, but you have to be careful in not devascularizing the nerve itself. So when you see vessels coming across the mesoneurium, you better be careful in terms of mobilization. You do not ever want to repair a nerve under tension, because when you repair under tension, there is going to be retraction. And if there is retraction, remember, the proximal ends need to find the distal endoneurial tubes to grow into. And if there is a gap, that will be detrimental for nerve growth. As a result, you will not have a proper recovery. The most common donor nerves that we use are the sural nerve, the medial cutaneous nerve of the arm, and the lateral cutaneous nerve of the forearm. We tend to use the sural nerve most commonly because of its length and ability to provide multiple cable grafts. We always use about 15% more than the defect itself. And I just use the term called cable grafts. So because the sural nerve diameter is not good enough, if you're repairing an ulnar nerve or a median nerve, you have to put multiple grafts, multiple cables in between, and suture the individual fascicles to the main nerve. So this is the cable grafting. So it's a cable graft. There has been interest in vascularized ulnar grafts. Remember, I said when we are mobilizing the nerve, do not mobilize too much to destroy its vascularity. So it was theorized that if you were to take a vascularized nerve graft, which brings its own microvascular blood supply, you should have better outcomes. Now, unfortunately, you do not really have a lot of donors for this. One specialized area that you can get a vascularized ulnar graft is the vascularized ulnar nerve. When you have a supraclavicular brachial plexus injury, where the C8T1 roots are injured, you know that the ulnar nerve distally is not going to recover. So now you can take that ulnar nerve from the forearm and the ulnar collateral and use it for as a vascularized nerve graft. But the jury is not very clear whether these grafts are better than non-vascularized nerve grafts. There is renewed interest in the use of nerve conduits, which is, instead of the autographs that we are using, the nerve graph, can we use any biological or artificial substances to bridge the nerve graft and use neurotropic factors to allow the proximal end of the nerve to grow into the distal end? Biologically, vein grafts have been used, freeze-thawed muscle grafts, and collagen. Non-biological grafts like silicone, plastic, and PTFE have been used. The most success in terms of these vein grafts have come, in terms of these bridging conduits, has come from the use of vein grafts and collagen, which is nothing but a type 1 collagen. And it has been shown that the defect has to be less than 3 centimeters to have any reasonable outcome in these patients. But there is a lot of enthusiasm and there is a lot of research going on in this area in terms of laying these conduits with collagen fibrils that will allow as conduits for the proximal end to grow into the distal end. How do we grade our recovery after repair? So this is the Medical Council Research Council scale for motor and sensory, and goes from M0 to M5, and kind of similar to your motor system examination for muscle power, but it's just that you want to evaluate in terms of nerve repair. It starts from perceptible contraction in the proximal muscles and distal muscles, contraction against gravity, strong resistance, and a full recovery in muscles. And when it comes to sensory recovery, you want to talk about finally the static sense of 2-point discrimination and motor sense of 2-point discrimination, which would be your ultimate recovery. Let me categorically state that we really don't achieve, the goal is to achieve 100% recovery, which we tend not to get in all cases. Let's look at some of these injuries. So these are all tidy injuries. That is, these are caused by sharp objects, knives. Here is a nerve injury on bottom right-hand corner that you can see the nick that is happened by the penetrating injury. You can see the penetration in the muscle, and it basically had a hematoma that compressed the nerve and caused intense pain and neuropraxia. And because it was a penetrating injury, we ended up exploring, and we could see that this nerve was intact. We just had to evacuate the hematoma, neuralize the nerve, and it was okay. This one on my bottom left side, you could see that there is a partial injury. This is the ulnar nerve. You can see the flexor carpi ulnaris. This is the ulnar artery that is there. And this is the ulnar nerve that is just about partially severed. And once you see that this is a partial, and you can see this was the original injury, the stab wound went in an ulnar direction. In this, it's a basic transaction of your forearm. Almost all structures are divided, and you can see your median nerve is divided, your ulnar nerve is divided. You can identify both the proximal and distal. And these are the kind of injuries that you go ahead and repair them immediately. Whereas this is an untidy injury. This is a shotgun injury with the entry and exit wound, loss of skin tissue, loss of muscular tissue. So what you're trying to do is doing a stage repair. You do a debridement, you repair your muscle, you do your tendon grafts to repair it, and then you're planning to do your soft tissue cover. You basically tagged your nerves and you lift them intact. You're not dealing with them right now. So you're going to cover this with your flap, get an adequate healing, and then come back and deal with the nerve injury. So what are all the factors in prognosis? These are 5 important factors. Age. Younger the patient, they have better results, because this could be because of their increased growth potential, the better plasticity of their brain, and their ability to adapt. The level of lesion, as is very evident, more distal the lesion, better the prognosis. Proximal lesions going up towards the axilla have poorer prognosis. The nature of the nerve injured. Even though we tend to talk about pure sensory, pure motor, we need to understand that, that there is nothing like no pure sensory or pure motor, because even these pure nerves carry postganglionic sympathetic fibers. But as you know, a mixed nerve, a larger mixed nerve with many structures that it is innervating, sensing both sensory and motor, will have cross connections, increased cross connections, and therefore might have a poorer outcome. Whereas a spinal axillary nerve that supplies two muscles, when repaired, will have a much better outcome. The timing from the time of repair, the earlier the repair, the better the recovery. And as I talked about the cause of injury, tidy versus untidy versus traction. Rehabilitation is a very important aspect of our nerve repair. The aims are that the rehabilitation helps us assess the disability and measures the outcomes. It reduces the degree of disability by physical and other therapies, and it allows the patients to return back to work, either to their original work, or if the injury is so severe that they cannot return back to their original work, that their work needs to be modified and restore these patients to have a significant independence in their activities of daily learning. There are various modalities. I will not go through all of them. You use splinting during the acute phase and the recovery phase. You also have graduated therapy with clearly defined goals. That means there has to be a clear-cut discussion between the surgeon and the therapist. What are we aiming? When are we aiming to recover these things? And you have to tailor to each patient's specific needs. Modalities like massage, transcutaneous nerve stimulation, percussion, and active mobilization are all important. You also do functional training and functional splinting. That means you're retraining your muscle. You're retraining the person to use their recovering muscles in such a way that maximizes their functionality. You also include the return to work training. So it's important to understand occupational therapists. They will include in their therapy the things that they will use in their workplace. So for example, somebody who's sitting at desk and using a keyboard needs to have something similar at the therapy so that they will figure out how to work with their keys. Whereas a driver who's operating heavy equipment needs to understand that aspect of therapy. It's also important to do sensory recovery and sensory retraining. You have to retrain your sensations based on what you're recovering. So there is both motor and the sensory aspect. Let's go through certain special considerations. There are nerve transfers. These are some of the things that are come up. These are some of the latest things that are being advocated. There is both sensory nerve transfer and motor nerve transfer. What do you mean by transfers? You have an injury in the nerve and you do side-to-side anastomosis. So if you have a very critical loss of sensation, this is the nerve that is damaged. You actually use a donor area and you critically re-innervate this before you even do recovery, if the recovery is not possible. So for example, in the hand, if it is very important, let's say for the little finger sensation, somebody who is a pianist or who needs his keyboard sensibilities and has an ulnar nerve damage, you can actually use the palmar cutaneous nerve from the median nerve to the ulnar nerve, or you can use the digital nerve from the third web space and re-innervate the little finger ulnar digital nerve. Similarly, you have motor nerve transfers where you use the anterior interosseous nerve that is serving the pronatus quadratus. You can take that nerve and re-innervate the motor branch of the ulnar nerve, especially if somebody has a very high ulnar nerve, because they will not recover their small muscles. So you can do the repair of the ulnar nerve proximally, but distally for the recovery of your small muscles, you can do an anterior interosseous nerve transfer. Similarly, for radial nerve injuries, proximal or high radial nerve injuries, you can actually transfer the palmaris longus or the FDS branch to the posterior interosseous nerve or the ECRB branch to allow some recovery of the muscle function. A special consideration will be lesion in continuity. Remember the picture that I showed where there was partial injury to the nerve? If this patient presented late, he would be presenting with a neuroma, and he would be presenting with a painful neuroma. What do I do with this injury when the patient's present late? It's a very difficult decision. It depends on what is being lost. So clinical examination is important. You need to understand what is the patient's deficits are. And when you go in, what are you going to find? If you find a soft neuroma, and when you open the neuroma, scar tissue, it's like just gently doing adhesionolysis. When you open the scar and you see intact nerve fibrils inside, then you leave the neuroma alone. If you open it and you only find scar tissue, then you divide this. Then you divide the neuroma, excise it, allow the new nerve fibrils, and then repair this lesion in continuity. So this is an on-table decision that you have to make. One of the more complex problems that we tend to face, both in general surgery and in plastic surgeons, is the presence of a peripheral neuroma. This is an inevitable and unavoidable biological response of your proximal stump. When you divide it, especially when you are amputating the various parts of the limb, whether it be digits or whether it be lower limb amputations that we do. The neuroma, as we all know, consists of Schwann cells, the growing axons, the fibroblasts, and blood vessels. Now, these axons could be sheathed in myelin or they could be unmyelinated. These neuromas are painful when there is persistent mechanical or chemical irritation. That means the nerve is stuck in a scar tissue or is adjacent to a bony process or a tendon process, or is in a mechanical pathway. Or there is spontaneous activity within the dorsal root ganglion accompanying with persistent stimulation of the axons. So these neuromas are more common after partial injuries to nerve trunks or injuries to the terminal branches of some specific cutaneous nerves. The medial cutaneous nerve of the forearm, the superficial radial nerve, the sural and the long saphenous nerve. So a lot of us, the people who assist the plastic surgeons or the hand surgeons who operate on the de Quervain's disease, or when there are lacerations at the radial border of the wrist, we always worry about superficial radial nerve. We always want to repair that nerve because leaving it open leads to serious neuroma. You don't really have the autonomic zone is the first web space on the dorsum, but it's the disability after that nerve injury that causes us to deal with that nerve much more aggressively. So the treatment of painful neuroma is very unsatisfactory. There are, as easy as it sounds, there are so many different methodologies described. So therefore, prevention is better than cure. When you are dividing your nerve, make sure you have a clean transection and you try and bury these nerves into proper healthy tissues. When you have a nerve injury, try and repair them. The medical treatment and the therapy of using splints, the nerve stimulation or sclerosing agents, which I have no experience personally, are all been described, but the results are varying. The surgical treatment is the most preferred option, and the best option is to go ahead, resect the nerve, damaged neuroma, and repair the nerve with or without grafts. This will always lead to a good outcome. If there is no repair, but this is a terminal neuroma, then resection and containment of the neuroma. That means you put that new nerve end into a healthy muscle, or drill a hole in the bone and put it in the marrow, or put an epidural sleeve or a silastic tube, are all described. Or you can also translocate the neuroma itself. Like, you don't want to really resect the ends, but you translocate the neuroma without excision into healthy muscle or bone. One other special area that I would like to mention, these are my last couple of slides, is the facial nerve. We tend to get called, plastic surgeons tend to call, especially when there are massive lacerations on the face. And the most important way to deal with facial nerve lacerations in traumatic area If it is the laceration is in the preauricular or in the cheek, where there is defined branches of your pes and sinus, which is the temporal, the zygomatic, the buccal, mandibular, the cervical branches, go ahead and repair them. But if they are more distal lacerations, by closer to the eye, angle of the mouth, or by the nose, you don't have to specifically look for the branches itself, because the branches have arborized, they have made into so many different muscular branches that once you repair the muscles, there will be neurotization of these muscles effectively. There is a separate grading scale for facial nerve injuries. It is mentioned here, that will give you comparison to the opposite side, and some of the techniques in reanimating the facial nerve, if the patients are presenting late, is to do cross nerve transfers with the help of grafts using the opposite side, and try and animate the individual areas. You want to know what area is affected and what do you want to do. It could be the closure of eye, or the angle of mouth elevation, or the lips. Or you can also do nerve transfers by transferring a hypoglossal nerve, hemihypoglossal nerve, to a facial nerve, so that you can reanimate the face. Finally, the two last things, radial nerve injury and humerus fracture. There is a controversial topic. There are so much discussions that happen in each and every hand meeting and any nerve meeting. There are two proponents, early exploration and versus late exploration. Early exploration, the indications are if you have an open fracture, where the fracture of the humerus is not satisfactorily aligned, or fracture is associated with vascular injury or with multiple trauma, and you're going in to fix them. The advantage is that you can ascertain the status of the nerve very quickly. The fracture is fixed under visualization and easy to perform. And I have to mention that this is my preferred approach. But late exploration, if somebody is presenting late after a fracture, you treated the radial nerve, the humerus fracture in a closed manner, or you've done IM nailing, and the patient is presenting to the plastic surgery clinic a little later, then you wait the whole 4 months. You're waiting for the recovery of the brachioradialis. Remember, you need to identify the level of the fracture, where the radial nerve is injured, and measure the distance and identify the length of time. And you have to patiently wait anywhere between 100 to 130 days. Once you see the brachioradialis recovery, then you know this patient is going to recover. If after waiting for 4 months or 5 months, you've given adequate time and the patient has not recovered, you then go ahead and explore. The advantage is that majority of the nerve injuries that are neuropraxic or axonotemesis will recover, and you don't need to really go ahead and deal with it. The fracture humerus is healed. And remember, we said that your motor end plates and your sensory end plates are still available for up to 12 months. Therefore, you use that methodology. Finally, the lower limb extremity nerve injuries. We don't really pay much attention to lower extremity nerve injuries. There are so many reasons why you get nerve injuries in the lower limb. But iatric injuries are the most common, especially when patients get intramuscular injections. If they have not given properly, you are likely to injure the sciatic nerve, the common peroneal branch more commonly, total hip prosthesis operation, excision of tumors, and tourniquets or traction or pressure during operation. In one of the largest studies that has been reported from Louisiana State Universities, they did look at 800 cases, and their results were that the results are better when you repair in the thigh than in the buttock. Tibial nerves are better than common peroneal nerve divisions. If you are repairing at the level of the knee, tibial outcomes were better than the common peroneal nerve. In general, common peroneal nerve seems to have a poorer outcome as compared to the tibial outcome. This is depending on a lot of different reasons, including its blood supply, its ability to move. Again, grafts have better outcomes for thigh and for tibial nerve lesions. As I already said, tibial nerve at the level of the knee leg has a better outcome than common peroneal nerve. You do want to treat lower limb nerve injuries, but you have to identify each patient separately and deal with them on a case by case basis. And with that, I've come to conclusion. It's 9 o'clock. Thank you very much.